Hello, everyone. It looks like we are live, and now we have an opportunity to address some of the questions from our audience that may have come up when we ran out of time. So I'll just pause briefly and see if any questions show up in the chat for our panel. And I think Eva will be joining us momentarily here. So one thing I'll posit to the group that I'm thinking as we go through these various presentations, and all of them were fascinating and phenomenal in their own way, I think about how some of these concepts can be leveraged together, to build a better contextual picture around what's happening pre-symptomatic, perhaps for patients with Alzheimer's disease. Maybe we can begin by, sort of just kicking around some thoughts with our panel on how to sort of marry these concepts. And I'll say that before Eva jumps on here, I was thinking about and jotted a note down about salivary lactoferrin possibly also being looked at in the context of infection-related biomarkers. And then other diagnostic methods like perhaps olfactory testing or even some of the speech testing that's being used. So maybe just some ideas from our panel, about how to bridge these topics or maybe how to leverage them together.
Mm-hmm. Sure. I mean, I can start if you like,
Please,
Nikki. I mean, I would postulate, wouldn't I, that genetics actually is a great place to start in the sense that we're talking about inherited risk that is fixed. Okay, so it's not a dynamic biomarker that will change over time, which of course have their applications in monitoring disease progression or monitoring the effect of therapeutic intervention. But I think establishing a baseline of genetic risk against which then to establish then a more regular monitoring regimen for dynamic changes in those at the highest level of risk, to me is a sensible starting point. And I notice in that context that Lavinia has asked a question about what is a good time to do profiling. Well, I think that very much depends on individuals. I mean, we find working with clinicians, particularly in the US, that a lot of people are interested at the time of early symptoms associated with mild cognitive impairment, let's say, to know whether or not that may be due to Alzheimer's disease in the future or perhaps anxiety, stress, depression, or some other cause. So that's one group. The other group is a much younger group who have perhaps family history of parents or grandparents who've developed the disease in the past and want to know whether they've inherited some level of risk. So, I think we have to think about both groups actually in that age setting.
If I could add to that, I do think also it's a broader health question. It's not just neurodegenerative. Like, people do make the argument that it's most cost effective just to genotype or even genome sequence newborns. Possibly that may be what will happen, but there's a lot of unknowns in the data. And there's a lot of people don't want to know, and there's a lot of people that we, from a clinician's point of view, we can explain to people. So my personal opinion will be eventually it'll become standard of care early in life that people will have their genome sequenced, and maybe every 20 years or so, but it's a bit science fiction-y still. But I think there is value in having that information as a baseline for predicting your long-term health trajectory for a number of health scenarios.
And it would seem that genetics would also help provide a really necessary puzzle piece in terms of better understanding our vulnerability to insults, right? I mean, whether they're environmental insults, dietary, lifestyle factors, educational factors, emotional factors, or even things like, external, like infectious diseases. We're seeing that with the present pandemic, right? That different individuals have a different propensity to develop very severe disease, and even neuropsychiatric symptoms following COVID. So what are the genetic sort of underpinnings that leave one person more vulnerable than the next. And that would be incredibly helpful to understand.
Yeah, perhaps in that context, one thing that I think we have learned from research on life course factors is that these are important context factors to consider, and I think there needs to be some kind of perhaps like socioeconomic risk profiling as well that is heavily interacting with the genetic risk factors. So I think that's an important point, and I would agree that also this is not something that's set in stone. I mean, there are heavy influences at the very beginning of the lifespan, but obviously these context factors also develop across the life course. So I think these kind of context factors need to be taken into account when really trying to understand the risk profile in that regard.
Yeah, I completely agree.
Sorry. Do you hear me?
Yes.
Yes. I wonder if an interesting moment to go more deeply in the life of a person, because to go deeply in the genetic context would be this what we call subjective cognitive feeling, because it's a particular moment of the life which until now has not been considered as important to detect mild cognitive impairment, but there are quite a few studies who show that there is some kind of hyperagnosia. So people realize that something is happening or starts to happen while all the results in cognitive testing are normal. And it seems that there are, particularly in this population, a clear increased risk of developing problematic neurodegenerative disorders. So it's very, as a clinician, I find difficult maybe to start genetic evaluation in 20 years before, unless there is a family history or something like that. But this part would be, I think, would be quite interesting to study. I don't know if you. It's very interesting that what are used, clinicians used to call them before, dementia specialists, behavior neurologists, behavior psychiatric and things like that. And the question would be, are we going to get more in, and I don't know, specialists in amyloid, specialists in genetic for neurodegenerative? So it's something which is not clinical, but maybe there is a certain moment, and we know that at that moment, studies shown that environmental factors, for example, still function to delay some kind of MCI. And so that would be an interesting moment.
I agree. I mean, I think what genetics can do is actually, in those situations, when we're talking about things like subjective memory complaints, I think genetics can add a bit of objectivity and take away some of the kind of clinical judgment, or add to the clinical judgment, really. I mean, it's with all these lifestyle interactions and factors and the sorts of things, the cognitive reserve contributors that we heard so eloquently discussed earlier, it's very hard to actually quantitate those, I think. I mean, age is a good surrogate, which is what we use in our models for lifetime exposure to these things. But we need more, clever ways, I think, of combining these things in objective and measurable and quantitative ways. But I think genetics, if you know that, if you're dealing with an individual as a clinician who has a high inherent genetic risk, and you're talking about early symptoms that are fairly non-specific at that stage, I think it can add to your certainty of what kind of patient and future trajectory you may be dealing with. I mean, that's what I would claim. I can see Edward nodding in agreement. I think Parkinson's is kind of in a similar situation, really, in terms of genetic understanding to Alzheimer's disease now.
And I think your point is important. Everything's a probability, and we're still really playing in the very tail end of the bell curve, where we know there's a large effect and we can see what's happening. But most people live right in the middle, and it's really a probability. So it is largely modifiable, which is, I think, interesting from a treatment point of view, that these trajectories are modifiable.
So we do have a question in the chat. Is it possible to have a panel of genetic biomarkers for predicting a polygenic disease like Alzheimer's disease?
Well, I think that's what we have essentially. I think the polygenic risk algorithms, which by the way were originally developed in schizophrenia and have now spread to other areas. I mean, they take into account all the genetic variants that we know about, which have been identified through statistical genetics approaches. I mean, our algorithm actually takes into account about 112,000 different variants that all contribute. Now, as Edward pointed out for Parkinson's disease, some of these variants that we pick out for prognostic purposes actually probably point to the same underlying functional or causative variant. But that's okay because no genetic test, is going to pick up every variant every time. So you need some sort of redundancy, if you like, in the algorithm. But that's how we go about that. So obviously ApoE is one component, but there are, tens of thousands of other contributors as well. So I think that's what a polygenic risk score tries to do. We published work with the Cardiff team and with John Hardy to show that why we believe that the number of SNPs that we actually assay in our test is optimal to cover all the commonly associated variants.
We have a little over 2.5 minutes left. Irene asks a question here in the chat that I think is more of an overarching, real world question, which is about translating this knowledge of risk factors, for example, the finger study, cognitive reserve, et cetera, to the broader population, in a prospective sense for patients to know how and where such risk factors can be assessed. It's kind of a two-part question. Does anyone want to comment on that?
Mm-hmm. It's a great question.
I mean, I think that's the general question of how to translate this into public health policy also, and I think that's certainly something where we know that certain socioeconomic context factors early in life do have detrimental effects that we can measure like 70, 80 years later. And obviously, this is then I think this needs to be turned into policy at some point. And I think that's the medical kind of health individualized type of consequence, but there's also the public health consequence, and I think that's an important part that we need to consider when we talk about that. So I think we all basically there are lots of study and trials underway where we test specific mechanisms, but they can obviously also be translated into broader policy advice.
I still think that he needs to be a huge educational program, though. If this is going to happen at the right time, probably in primary care or general practice, then most of those physicians today are not aware that these factors can be addressed and can change outcomes, and that's a real fundamental gap in understanding. I think it needs to be.
I think we have the data for that. Already the 2013 Matthais paper on Lancet Neurology showed that the incidence per year per age of dementia decreased between 1990 and 2010. That's completely at the opposite that all what is say that dementia is increasing, and that really was the first sign that all the prevention started in the 1980s, 1990 started to have a significance. So we have shown that already that this kind of action have an effect. And probably to answer to Irene, what we have now in our studies is maybe focused on at-risk populations more to demonstrate to have a more coherent and with a stronger effect size the demonstration.
Jean-Marie, I'm very sorry to interrupt, but we have to conclude this session so that the next one will begin. Thank you, everyone, for wonderful presentations. I really appreciate it. And we will all be on the next session 2. Thank you so much.